The question about success rate is an important one. So there have been no real long-term studies looking at long-term outcomes from this. This is very different than what we're doing. We're looking specifically at long-term outcomes following these surgeries, okay? Typically, when surgeons talk about the results, they will talk about a reduction in volume of what is thought to be about 20 to 30% for the lymphovenous bypass. But what they focus on is the qualitative aspect of it. Most patients after the surgery feel less heavy. They have less heaviness. They have less pain in the limb. For a lower limb, they're able to do their exercises better. They're able to walk up the stairs. What I tend to say is that the CDT, which is the combined decongestant therapy, is the mainstay of the treatment. You're never not going to do this, right? There is no cure for lymphedema. The surgery is an adjunct, so it helps you do the things, and hopefully we're hoping that it will reduce the amount of time that you're spending on your lymphedema care, right? So, but what we are doing with our outcome studies is we're looking not only at reduction in volume with measuring the lymph, but also like having patient interviews and asking them several questions about what their life was before and after surgery.
So I know people are out there wanting to know. So you want to get a referral from a doctor to see somebody like you for surgeries?
Yes.
What makes you eligible? That's, I think, something people are really interested to know.
So a diagnosis of lymphedema makes you eligible. Okay. So typically, not all family physicians will diagnose with lymphedema. So that's one. And honestly, then you just need to send a referral to me. I typically get my referrals, or to whoever surgeon is doing this type of surgery. I typically get the referrals from the PMH lymphedema program. So they're the physicians and the physiatrists that are working there who will send the referral to me. We have a special referral form. I've also met with a lot of therapists across the city, which are aware of the type of work that we do here at the UHN, and they will typically be working in conjunction with either another surgeon or a physiatrist or somebody else that will typically send the referral to our office. It is not a difficult process. So, yeah.
So how you're self-managing on your own before you ask for the referral doesn't matter so much?
No, it doesn't.
Okay.
So what's important to me, though, and the reason why, what's interesting is that the patients who are being seen in the PMH clinic are almost like self-selected group of people and a population, because what is important, and it is an important process, is, and that won't prevent you from seeing me in referral, but we know that the people who do better after surgery are the ones who were very compliant with their CDT and their self-management prior to surgery. We have evidence of that. So typically, the ones who are the ones who are who undergo surgery have to go a very rigorous compression techniques before and after surgery. And the ones who have been very compliant with their self-management already know how to do that. So it's very easy for them to go through that. And the ones, some will say, oh, this would be very difficult for me to do, right? Like the self-wrapping and things like that. So then I would worry that they would not be able to do the 6 weeks of multi-layered compression, and so it's a total of 8 weeks where they would have to do 3-layered compression for the lymphovenous bypass. So, that how well they do doesn't change whether or not I see them, but whether or not they're candidates for surgery, that's very, very important. Like how much can they self-manage, and are they, I don't like using the word compliance because it just makes it seem, it's just not I don't like using that term. But it's just to remind people that like the surgery is not a cure, right? So does that answer your question?
Yes, yes. So it's not mandatory, but if you are doing self-management that is really compliant or consistent, let's say,
Yeah.
and well, you're going to do
Yes,
better on the back end. So personally,
absolutely.
you'd be a better candidate, not necessarily the
For
only
sure.
candidate. Okay.
For sure.
So we've kind of covered some of what is my next question, which was what type of self-management protocols should patients expect to have to do consistently after these treatments?
Yeah.
What would you say are the top things that they need to do?
Right. So two things that are mandatory. So prior to surgery, compression is key. So at least 2 weeks prior to compression, we go through a 3-layer compression. They are seen by our therapists prior to surgery to show them how to do the self-management in a 3-layered compression. This is done 2 weeks prior to surgery and 6 weeks after surgery for lymphovenous bypass. 2 weeks after surgery, massage becomes mandatory, but the massage is very different than the typical lymphedema massage, where you sort of go away from the limb and go proximally. So what we do is we do another technique where we do the massage towards the bypasses. So there are several bypasses that are performed on the limb. At least 3 bypasses are required for good results. So patients will have multiple incisions on the limb. And then the massage is made towards the actual bypasses. And the reason for that is because the suture technique that is used, where the lymphatic vessel is sutured to the venous, to the small vein, these are both low flow systems. Typically, an artery sort of pushes blood and it's a high flow system. So any connection that is made would keep it open. This is not the same thing. It's a low flow. So you need to actually give it some form of pressure in order for it to remain open. So then the massage is actually done towards the bypasses. So those are the techniques that would be expected for a bypass. The lymph node transplant is a little bit different. In the first 2 weeks post-operative phase, because this is a transplant of nodes that we're taking from one part of the body to the other, we try not to wrap it and put too much pressure on it because we want to make sure it's still functional and it maintains its blood supply in order for the new vessels to be recreated.
Great. I think that's a lot of information that most people they've maybe heard about it, but there's no practitioner that's talking to them about it. So I think it's really valuable information for someone to know a little bit more.
Yeah, for sure.
Okay, so your research is focused on tissue engineered techniques for tracheal reconstruction and the immunology of vascularization, composite allotransplant plantation. Can you explain to our followers what that means? That's a lot of words. I had to read because I couldn't remember them. What it could mean for the future of healthcare.
For sure. So my research focuses on, vascularized composite allotransplantation basically means the transplantation of a non-solid organ. So a solid organ is an organ like the heart, the liver, the lung, and the kidney. There are other tissues and organs that we can transplant. And those are typically transplanted for patients who have disfigurement or have had a trauma, or, for example, for burn, or patients who have had amputations. So this would basically be the transplantation of things like the face or a full limb or the airway, right? So, so my research really focuses on the immunology of this. So very much like solid organs, where these organs are procured from a donor for I'm going to say VCA for short. For these tissues, they're also procured from an organ. So we have a chance of rejecting these organs, right, and these tissues. So the goal of my research is to try to find techniques where we can reduce the amount of anti-rejection medication that is provided and given to the recipient, because we know that things like anti-rejection medication can lead to hospitalization, infection, cancer, and has a lot of side effects. So particularly for the airway, that was the focus of my PhD thesis when I did a PhD thesis. And I looked at taking a donor airway, removing all the cells, keeping the scaffold and all the cartilage intact, and using patient-specific cells to repopulate this airway prior to transplanting it. And that way we would hope that it would reduce the rejection of this organ. And now I'm doing similar techniques for things like lymph, as well as face, in order to, again, improve the quality of life of these patients. Yeah. And I'm happy to go in more detail if you'd like, but I'm not sure if you're interested in that. Yeah.
I have no questions at the time. Deborah, do you have any more questions about that one?
No, because I think it just leads right into the next question. What are you most passionate about?
Yes, you can tell.
You know, I think all of my work really ties in together, which is nice. I think, my clinical work really ties in really well with what I do on the research side. It was nice to be able to come back to an academic job like I have, because I have always been very passionate about doing research. Okay. And I do think that in order for us to really improve healthcare and to advance, research is what does a lot of that, right? So, and I've also sort of been always very inquisitive and curious and just want to find new things and new techniques to make things better. And I think the research, my research component really helps me to do that. So, yeah, I feel like I've sort of found the best of both worlds to be able to sort of dedicate and, my time to operating, which I love to do. And, I always see myself being in the operating room and still take that time to sort of, find new novel techniques, and try to find solutions for patients who currently have no other solutions available to them. So.
Well, I know we're thankful that you're here. All right.
Your passion so shines through that last question before,
Thank you.
Beautiful, beautiful to see. All right. Is there anything else you'd like to add or tell our followers, let them know before we sign off?
I just want to let people know that, you're not alone. I think what's important for you to know is that it's, lymphedema is also is a lot of people think that it's not prevalent, and it's actually very prevalent. And I think that you have to remember that there are things that we can do, and there are people who are very interested in trying to help you get through this. And we don't want you to feel that you're alone, and that we want you to know that you have access to people that can share their experience with you, but also hopefully provide you with some solutions and, different treatments and techniques. I also want people to know that I'm always available to, accept even referrals from out of province. And I actually do get a lot of emails from other people. And even if they just want to have a virtual discussion or a consultation to talk about, things that they've gone through. So my office is always available if anybody's interested or if they just have any questions. Yeah.
And is that for people out of province and other countries as well? You're open?
Yes. Yeah, right. I have seen a lot of international patients as well. So I'm more than happy to sort of, talk about different techniques and options.
Great. Yeah. Yeah, that's I think what most people want to hear, and especially in the times that we're in, people want to hear that encouragement from a physician like yourself, who is so knowledgeable in what you have to offer, that they can have access to it, that they can tap in. And that's kind of, what we do with Conversationally, is make sure that we share this. And so I think we're in agreement, aren't we, Bisa? We are so thankful that you were part of this whole series that we're doing.
Yes, thank you so much for your time today. Really appreciate it.
Yeah, I want to thank you both for giving me this opportunity, because I think this opportunity will help me really reach out to other patients and other people who are living with this. So thanks to both of you for doing so much work, and you know, for also being passionate about this and wanting to help people.
Thank you.
Thank you.